Many people, including myself, are on omega-3 fatty acids because they think they are going to prevent heart attacks. I was taking over-the-counter omega-3s, but I was wrong. So I want to share this with you because it might help you improve your health. Many people will say I take over-the-counter omega-3 capsules because they're going to help protect my blood vessels. This is actually wrong according to the best research we have. So what actually works? We're going to go over the myths versus the realities of omega-3s and heart health, what pure EPA does. That's actually what shows benefit, including a 25% drop in major cardiovascular events, and then how to think about this in terms of safety and side effects. And at the end, I'm going to give an example of how I apply this in my life, in case that helps you. I'm Dr. Haque. I'm here to give you evidence-based insights. No hype, no gurus here. This is purely educational. Check out my newsletter, medicalwisdom.org, for deeper dives and more personal takes. Multiple randomized trials have shown that these supplements fail to reduce strokes, heart attacks, and death. These are not regulated like regular medications. They lack the purity standards, and recent guidelines actually recommend against using over-the-counter fish oil products for cardiovascular protection. Did you know that? I certainly didn't know that. I'm even a doctor. I didn't know that. So the first myth is that these over-the-counter omega-3 pills are going to protect you. They completely fail to show any reductions in these heart outcomes. Another major trial with diabetes over 7 years, they were taking 840 milligrams of EPA and DHA, which are the two components of omega-3 fatty acids. This showed zero cardiovascular prevention benefit. So think about the millions of people who spend billions of dollars on these products, thinking that they're going to help them. Total waste of money. I fell for it myself for many years. And if you want to look at the data, here's a meta-analysis showing basically no difference from the null result in the middle there. The other thing is, because these supplements are not regulated by the FDA, a lot of them are rancid. They have oxidation. Up to 24% of tested bottles exceeded oxidation limits. They're inflammatory. They often have hidden fats included. One study showed up to 36% of undisclosed saturated fats. Who knows what's in there? And when these things get oxidized, they're not going to really have good effects on LDL. So it's definitely the Wild West out there with supplements. Another myth is that all these omega-3s are the same. You have to consider EPA versus DHA. EPA is going to stabilize cell membranes. It's going to make that fibrous cap. When you have a lesion in your arteries, it's going to make it more stable, and it prevents the inflammation in the blood vessel walls. DHA is not all bad either, and it can raise LDL. So they're doing different things. You want to think of them as different components of omega-3s for different reasons. So personally, I don't take a generic omega-3 pill anymore because not all omega-3s are created equally. The other myth is that if you take more omega-3 fatty acids, you're going to get always better results. The risk of having a potentially fatal heart arrhythmia, such as atrial fibrillation, goes up by 50% when you're at 4 grams a day of omega-3s. We're going to go over this in more detail. You must consider the risks of these things as well as the benefits. We're also going to talk about bleeding risk, which is no joke. So you might be thinking, oh, omega-3s worthless then? What's the whole point? I've been duped. Actually, no. I'm going to show you what's beneficial in terms of the research. So hang in there. There's actually good news. There's something called IPE, which is a purified form of EPA omega-3, the EPA component of omega. It's available in a prescription format. It's called Vascepa, but you have to take it with food. Otherwise, it's basically not getting into your system. The form you're normally getting in the CVS or pharmacy is this triglyceride format, and that's the one that's not really effective. So we're going to focus on the effective form in clinical trials called IPE or Vascepa. It's a purified EPA. Here, what we've seen is a 25% reduction in ischemic cardiac events. This famous trial called the Reduce It trial followed people over 5 years, over 8,000 people, and the key dose was 4 grams per day. This is by prescription. So you're looking at 25-30% reduction in cardiac events, which is pretty amazing. However, it's not that simple. So there's another trial called the JELIS trial, which showed a 19% reduction, and we're going to talk a little bit about both of those. But as a reminder, the best trials on combined EPA and DHA, the non-purified form, basically show nothing. So again, not only are supplements not so helpful, but even when EPA and DHA combined are put in trials, we don't see anything. There's something about them when they get combined that doesn't really work. But when you see them in their EPA-only form, there's some benefit. That's the second major takeaway. I personally don't take combined EPA DHA anymore. So why did this EPA DHA trial fail? DHA is going to counter some of the actions of the EPA. It's going to increase LDL. It counteracts the antioxidant benefits of high-dose EPA. So just remember, if you Know somebody taking an omega-3 supplement, probably they're taking a DHA EPA combination supplement, and that has been shown not to do anything good. Now, when we look at these pure EPA trials, what's amazing is you see the coronary plaques in the coronary arteries of the heart shrinking. That's amazing. So they looked at CT scans of people's heart vessels who were on statins over 18 months. They gave them these 4 grams of EPA, and they noticed that their plaque levels actually went down, which is really hard to do. This is one of the few things that's been shown to decrease plaque, at least. And the placebo group actually progressed when they were just on a statin without this EPA. Their plaque actually increased by 109%. So, wow, that's a huge finding. But this is not going to benefit everyone. These studies only really look at certain at-risk populations. So patients who have cardiovascular disease or ASCVD patients. So they're doing secondary prevention. They have a prior history of something. Maybe they've had a stroke, heart attack. The other group is high-risk people with diabetes who are over age 50. And both of these groups have to have failed a statin or they're on maximally tolerated statin. So that's not everybody. So you can't just say that this purified EPA is for everybody. So let's go into this first group. Perhaps this is you or someone you love. Somebody's already had a myocardial infarction, a heart attack, and these people had the strongest survival protection. So 34% drop in recurrent heart attacks, 30% reduction in cardiovascular death, 40% drop in sudden cardiac death. That's humongous. These are amazing numbers. So if I had already had a heart attack, I would definitely look into this. Maybe one day I will, hopefully not soon. Now, the second group is people who have diabetes and are at high risk over age 50. So here we didn't see as much of a benefit, and that's why the guidelines don't necessarily recommend the 4 grams of high dose purified EPA for these groups. So this is something to talk about with your doctor. So you might be wondering, how does this 4 grams of purified EPA actually work? I think the most important mechanism is stabilizing plaque. It's hardening the cap that develops over plaque in the arteries. These EPA molecules, you find them more in those actual plaques when they're dissected. They modify the structure of the plaque. They thicken the capsule, which makes it less likely to rupture and cause a heart attack, cause a stroke. But they're also anti-inflammatory actions, and the inflammation, the cytokine cascades independently cause trouble. And thirdly, these benefits are independent of what's going on with triglycerides. Many people think of taking omega-3 fatty acids for triglycerides. That's great. But these benefits on cardiovascular function are totally independent of that. You don't have to lower your triglycerides to get benefit from omega-3 fatty acids, especially EPA. So stepping back, what did these studies show is who would be an eligible patient for some of these interventions. First of all, you can't be 15 years old or 25 years old. 45, 50, you have to have some established blockages. You have to have some high-risk diabetes. You have to have some kind of risk factors. You have to have already tried a statin, or maybe the maximum that you've been able to tolerate in terms of side effects. And LDL is really below 100. It's already been worked on for a while, and it's always a benefit to have higher triglycerides for this intervention because it'll help the triglycerides. So you want to think about whether you're even in the category of people who your doctor would consider for this. Who does not benefit? So general healthy populations, people who don't have any cardiovascular disease or diabetes, they don't show any benefit. People who are not even on statins yet, because that's not the study population, and people who are taking things over the counter. One caveat here is when you say healthy population, there's so much risk within the healthy population. So for example, to give you a personal example, I have very high LPA. So I consider myself a very high risk candidate. And that's why I looked into omega-3 fatty acids and the purified EPA for myself. Even though some doctors might consider me to be healthy, I haven't had a heart attack. I don't have diabetes yet, but I know I have a strong family history and I have high LPA. So I'm probably on the higher risk side of things. So you need to talk about this with your doctor. But no matter what group you look at, if you look at this trial, the Reduce It trial, you see a remarkably consistent benefit across nearly all subgroups. This is the hazard ratios, meaning the risk reduction ratios. And you can see all of these groups here on the left. Sorry, it's a little bit small, but pretty much all of them are to the left of this line here. And what that means is that whether it's people in different areas, whether they've tried Zetia before, male, female, race, age, diabetes at baseline kidney function, triglyceride levels, statin activity, etc., you see this general trend where pretty much everyone's benefiting in reducing their cardiovascular events. And that's a sign that this is doing something good for people. Now, you may have heard of omega-3s for brain health, but that's a different story. DHA, not EPA. EPA is more for cardiovascular benefit. It's also been studied in mood interventions. But other studies have shown that if you eat a lot of fish, there's a correlation with less dementia. So keep that in mind. You'd have to look into DHA trials. And even there, it's not the best research. It's not the best outcomes. So I'm not going to comment on it further. Just wanted to let you know that's something out there as well. However, you can go to your lab. You can go to Quest Diagnostics, LabCorp, whichever one your doctor uses, and you can actually request this omega-3 index tool. And personally, I've never gotten this tested. I'm gonna definitely ask for this next time I see my doctor. But what it does is it measures the percentage of EPA and DHA that's integrated into the red blood cell membranes in your blood. And this is almost like a long-term biomarker because these things take a long time to get integrated into those cell membranes, months. And you can tell if you have a low or high amount depending on what your goals are, if you're looking to have more EPA or more DHA. So for example, I would want to have a higher EPA component. So this is definitely a test I'm going to look into. Many people are worried about the side effects. Remember, high dose EPA has been connected with atrial fibrillation and bleeding. The absolute risks are actually low. They're not very, very high risks, but they are there. They're higher than when you don't take these things. And then there's the low level risks like GI symptoms, reflux, belching, the bad flavor of the fishy pills, etc. So let's talk about atrial fibrillation, needing hospitalization. So this is what people are afraid of. So remember, atrial fibrillation, atrial flutter, these are heart arrhythmias. The heart is not moving normally because of the electrical system being off. In most cases, this can be reversed. It's not deadly per se, but it is definitely a bummer. And you have to manage it with your cardiologist over time. And some people cannot get out of heart arrhythmias, and it increases your risk of stroke. So personally, I'm afraid of that. And we know that the more omega-3s that you take, the higher the risk goes. So if you're at about 1 gram or less per day, you're still getting a 12% increase in atrial fibrillation. As you get to 4 grams per day, it's up to a 50% increase. Now remember, 50% increase doesn't mean a 50% risk. It means that from the baseline level risk, it went up by 50%. So it's still an overall pretty low risk. So you have to consider risks and benefits with your doctor when you're trying to decide whether you want these things. But to be concrete, in this Reduce It trial, 3.1% of people had atrial fibrillation needing hospitalization compared to 2.1% in the placebo group. So that's about a 50% increase. But overall, it's still pretty low because remember, the placebo group has people who are also not so healthy. So atrial fibrillation is very common in the communities, in the general population. And by the way, you can even check for atrial fibrillation at home. You can listen to your own pulse and detect it. You can use your Apple Watch or your iPhone or whatever you have. And oftentimes they can check your heartbeat too. How about non-hospitalized atrial fibrillation? It was 5.3% versus 3.9% in the placebo group. Now that's a lot of people. However, if you have had an arrhythmia in the past, you're going to be at higher risk. But if you have not had atrial fibrillation in the past, the risks are actually lower, 2.2% instead of 3.1%, and it's barely statistically significant. If you see P of 0.09, technically statistical significance is 0.05. So, if I haven't had atrial fibrillation, just to be concrete, I'll tell you. So when I'm looking at this, I'm thinking, okay, well, yes, there's a higher risk, but I'm not somebody in that higher risk group. So maybe I want to take a risk with my doctor and talk about this, try to get on this because my risk is going up from 1.6 to 2.2. It's a little bit higher, but it's not statistically significant. Maybe I'm going to get benefit. Now, the other thing to keep in mind is that people who develop atrial fibrillation still have benefits for reducing their risk of developing cardiovascular events, heart attacks, strokes. So in these studies, you do see people with overall benefit even when they develop atrial fibrillation. So what is the dose that you could take of one of these things to get out of this danger zone? If you look at these trials of low dose EPA and DHA, of course, we know they don't work, but you can still see, did people in those groups develop atrial fibrillation, right? They're giving people about 840 milligrams a day, like in this Vital Rhythm trial. And you don't see any increase in atrial fibrillation. So what that suggests to me is that the threshold for getting into atrial fibrillation is going to be somewhere between 1 and 1.8 grams per day. Because in the studies of 1.8 grams per day, we do see increases in atrial fibrillation, but around 1 gram, 800 milligrams, we don't really see them. So if I was going to take this high dose, this high purity EPA, what I'm personally planning to do is try to go for 1 gram a day. And my goal is to try to get some of these benefits without getting the risks. What about bleeding? So the absolute bleeding risk is small. Remember, it's 0.6%. Serious bleeding risks were not statistically significant. They're a little bit higher, but not statistically significant in the trial. And in this trial, no fatal bleeding events occurred in either group, the intervention group or the placebo group. Also, they didn't see any differences in stroke, serious bleeding, GI bleeding. However, if somebody's on a blood thinner like aspirin, clopidogrel, warfarin, you have to be much more careful because there's going to be more likelihood of bleeding because you're combining the omega-3 fatty acid with this other blood thinner. So that's why I'm cautious. For example, I'm on aspirin, a baby aspirin, daily. So I'm worried about starting a high dose omega-3 fatty acid. Now, a couple more things to remember if you want to talk about this with your doctor. So for this purified EPA, you're going to reduce your triglycerides. It's approximately 18% reduction by 1 year. And you don't want to think about your cardiovascular benefits as connected to only your triglycerides. So even if your triglycerides don't go down, there's going to be independent benefits for cardiovascular events. So regardless of where your triglycerides start, this intervention has been shown, the high dose purified EPA has been shown to have benefits orthogonal or independent of that, probably for the reasons I mentioned: anti-inflammatory, stabilizing the plaque, etc. The DHA component of omega-3s, remember, it increases your LDL by about 7 points. The EPA component does not, so you don't have to worry about your LDL getting worse. The purified EPA also will reduce this high sensitivity CRP, which is an inflammatory marker, and oxidized LDL, which is not a good form of LDL, and remnant lipoprotein cholesterol. So we're worried about lipoproteins all the time. So those are all kind of side effects that are good. And the prescription grade EPA doesn't have as much of that belching, fishy taste, dyspepsia. That's more common with the over-the-counter stuff, maybe because it's rancid, maybe because it's not as purified. And the prescription stuff is not as allergenic. So if somebody has a fish or shellfish allergy, they can typically take one of these under supervision of their doctor. And step back, the big picture is that you should be eating a healthy diet, and real fish still performs well. So eating real oily fish twice a week is linked to overall cardiovascular reduction in negative events and mortality. I try to avoid red meat as much as possible, eat chicken, eat fish. Personally, I don't like the taste of fish, so it's very hard for me. That's why I'm interested in omega-3s. But if you can get yourself to eat some sardines, mackerel, salmon, great. That's still going to do wonders. But you don't want to double that with a lot of omega-3 supplementation. So here's how I see it. Eat the real fish, skip the retail bottles, talk to your doctor. That's a nice summary. And a number of you have asked me to comment on how I think about stuff in my own life, so I'm starting to do that a little bit more. So like I mentioned, I personally have stopped over-the-counter omega-3s. I used to take those every single day. I stopped the EPA and DHA combinations. I only take EPA now, and I stopped taking the EPA only over-the-counter as well. I'm focusing now on this Vascepa, which is prescription only. I'm going to be going to my doctor to talk about that. The way I interpret it is I want to aim for 1 gram a day, and I have to eat it with food, of course, because if you eat it not with food, it doesn't do anything. The way I think about it is based on the data I showed you. I think personally for me, 1 gram a day is going to give me some benefit. It's going to reduce the risk of atrial fibrillation, because we saw that atrial fibrillation goes to pretty much 0 at 840 milligrams a day. Although technically that was not the same as taking Vascepa. It was a EPA DHA combo. So I'm making an inference there, but I think I'm reducing my risk of atrial fibrillation to close to 0. And I do take aspirin, so I'm worried about the bleeding. However, maybe that's a risk I'm willing to take because there's cardiovascular benefits, but the risks are dose dependent. So as you take a higher dose, you do get higher risks of these things, but the benefits are also dose dependent. So you have to think about that as well. Is there any benefit on something less than 4 grams per day? Yes, there is. There is data showing that there is. So I'm going to show you in the next slide about that. And I'm also going to check the omega-3 index to make sure that this stuff is getting into my membranes and hopefully getting into any plaques that I have in my arteries, stabilizing those plaques, preventing heart attacks, preventing strokes. And I'm going to try to eat some fish, although I haven't eaten fish in a long time. Probably not going to. I'm going to try. If I had a heart attack already, if I had a stroke, if I had stable angina, I would probably find the risks of 4 grams a day worth it. But of course, you have to talk to your doctor. For example, my father, who passed away in January, he had stable angina, many heart attacks, and he had chronic atrial fibrillation. And I used to try to push him to get this, but he never took it. Here is a summary that I think encapsulates why I think the way I do. So here's a trial called JELIS. They use 1.8 grams per day. And what you'll first notice here at the top is that the cardiovascular event reduction was 19%. In the 4 gram per day trial, it was 25%. So if you go from 4 grams per day to 1.8 grams per day, you're still getting a pretty good reduction in your cardiovascular events. It's not going down proportionally and linearly. There's definitely a threshold effect. Same thing was seen in this RESPECT EPA trial, 1.8 grams per day. So if I took 1 gram per day, maybe I'm getting 10%, maybe I'm getting 12% benefit. I don't know, but I'm getting something more than 0. And that's what I'm looking for. The second thing is new onset atrial fibrillation. It wasn't reported in these trials, but if we look at the RESPECT EPA trial, 3.1% was the overall rate. And in the REDUCE IT trial, it was 5.7%. 3%, that's at 4 grams per day. So 4 grams per day, you're getting a 5% risk of atrial fibrillation. At 1.8 grams per day, you're getting a 3.1% risk. At 1 gram per day, it looks like it's close to zero. So hopefully it's worth it, for me at least. Now, in terms of bleeding, as I mentioned, I'm on aspirin, so it's probably a bigger deal for me. But as you go down in dose, you see you have a 2.7% risk at 4 grams per day, and you have 1.1% risk at 1.8 grams per day. So we're kind of like approaching something close to zero. And when you consider the benefits, you have to talk about with your doctor. You have to have some reflection in your own heart about what you're looking for and what you're willing to put up with in terms of risks. And these are crude comparisons. These are not direct comparisons. These are comparing across trials. So keep that in mind as well. Heart disease sucks. I hope this has benefited you. I hope it's inspired you. Check out this other video. Feel free to join my free newsletter, medicalwisdom.org, where I give some more deeper dives and some personal takes to your health. Take care.